You have a campaign for action, we have an action model, because we recognize that data are important, but action is even more important. And a data-informed social movement, which we are actually aligned in doing, is what will actually result in the very powerful changes that we hope to make. So I'm going to talk about some of the evidence base behind this action framework, the research based on it, but I'm actually going to start a little somewhere else. Because it's, I've had that, I agree, my title I like a lot. Chief Science Officer, that's a great title. But I've only had that for 2 years. For 25 years, I worked in frontline public health with health departments in Boston, Seattle, King County, Los Angeles. And as we put this together, this action framework together with my colleagues in RAND and all across the foundation, it was as much informed by those experiences, those frontline experiences, many of which, and the innovations in building a culture of health, even though we didn't call it that at the time, were innovations with my nursing partners. I just want to kind of give a quick summary of the many different ways that experiences that I had that were transformative in action areas that we really were in my early experience, where I, in fact, learned from my public health nursing and nursing colleagues about this kind of community engagement. I think back in the late 80s in Boston, when I was working there and we were trying to tackle black infant mortality in Boston and reduce those disparities. That was led, and the community interventions that were successful, led by our public health nursing workforce. The school health programs that were so successful in Seattle and King County, again led by my colleagues in public health nursing. On the clinical side, trying to improve the quality and outcomes of jail health in a complicated public health system in Seattle, King County. The leadership to try to make that more than just a holding company for a place for people with mental illness, substance use problems, to really make it preventive, came from our public health nursing colleagues. The toughest interface we had in that department, and representing a lot of opportunity cost of not having a culture of health for those folks. And it goes on and on and on until my recent experiences in Los Angeles County, both trying to build a sense of community resilience in that diverse 88-city, 11 million county person, but working very closely with our nurses around emergency preparedness. And just as a kind of a sober note, with those nurses and critical care nurses who were part of the response to San Bernardino, that was also in the continuum of the work that I've learned from, and just the vital role that nurses play in well-being, community outreach across the whole continuum. So I'm really hoping that you see yourselves in that entire continuum of nursing leadership in this model that we're presenting, because you're essential parts of all of that. So as Risa said, the research question we started out with was a simple one, really. What is holding our nation back from the health equity that we aspire to? And there was a two-part research question, sub-question to that. What do we know a lot about that we don't scale and spread? And what do we really need to know more about if we're to achieve health equity in this country? So the Culture of Health framework, the measures, the action framework, really came from that rigorous research with my colleagues in the RAND Corporation, but again, many, many researchers around the country and some in this room. As Risa emphasized, we call it a framework rather than a model because it's adaptive. And we hope as you get to be more comfortable with this model over the course of the next couple of days, you'll see that it's very adaptable in many different contexts to help organize our work and maybe measure our work around building a culture of health. And as I like to say about this one, we built this action framework from really rigorous research, but we really built it with rigorous listening and rigorous reflection. Thousands of people we talked with around the country, from the level of community organizers, frontline health providers, through very methodologies like concept mapping to just informal conversations over the course of a year and a half to really reflect not just the best of research evidence, but the best experiential evidence of what can get us to these health outcomes that we really are trying to achieve as a nation. So Risa did a wonderful job of introducing the action framework, so I'm going to not spend too much time on the diamonds, but just to really emphasize on that action area 1, this is really about changing the narrative, the default narrative narrative, which in our healthcare, which in our system tends to orient itself too much toward the critical, catastrophic part of care, and not as enough balance to the preventive sides. How do we change that discourse? How do we change that narrative so we embrace all the forms in which we promote health and healthcare, being as preventive as is possible in the continuum? And again, nursing plays a big role in that. Fostering cross-sector collaboration. Nurses, in my experience, have been some of the best collaborators in the work that we do. And I think we're trying to extend that collaboration, not just across healthcare, but multi-sectoral collaborations outside of health, because as we know in the social determinants of health, if 70% of what drives health and well-being in our country are not the things we do in public health and healthcare, that means those assets are somewhere else. They're in private industry, they're with urban planners, they're in other sectors. How do we align those sectors and their assets and their thinking to join us in this movement to build a culture of health? Certainly it's action area 3, creating equitable, more healthier and more equitable communities. And in my experience, the innovation that I have seen in improving community health, understanding the role of the built environment, visiting nurses that I knew with told us a lot about the relationship between housing and poor health than we ever saw in my epidemiology offices. So I think that those are the kinds of things that you are all really well versed in and help to inform this. And then again, action area 4, which I'll spend a little bit more time on in the end, strengthening this integration of health services and systems, allowing all who are providers of health to operate at the maximum level of their abilities without restrictions. Those are very essential parts of what it takes to get to action area 4. So as Risa said, the thing about this action framework is that we're all in it together, and I just want to really emphasize what she emphasized, that the core of what we're trying to do, and you see it all over this action framework, is equity. Closing gaps, not just measuring them. So that's really what we're about with this as a whole. And again, as Risa pointed out, culture is a very nuanced concept. We have many different cultures in this country. There are many different cultural pathways to building a culture of health. And this framework intends to recognize all those nuances, all that variation as we work to build a culture of health, not in a strict blueprint way, but in a catalytic way. So I am the Chief Science Officer, so I do have to talk about the measures. I know that. It was hard to keep them at 41. And I just tell you a little bit about them. You have these as handouts. I have never dared to give a 41 measure talk. I don't think anyone would sit through it. It's probably a good idea on my part. And you have the handouts. But they're important because they represent national data. Very important, as Risa said, that it represents the lifespan and health span. The culture of health is open to people at all ability levels, really focusing on broad determinants and upstream drivers, why you see some things that aren't mortality and morbidity indicators, and really to appeal to multiple audiences. These measures, as you look at them, they were chosen to engage the unusual suspects, the corporate leaders, the outside of health leaders, the Federal Reserve, bankers, into what is their role in achieving health equity. So think about that, and again, equity being a very core part of what we're trying to do with this. So let me, again, I'm just going to hit very quickly in the diminishing time that I have to go over just some of the kinds of things that Risa did. This changing the narrative of health, this developing more of a sense that we are all in this together might be the critical health problem or well-being problem confronting the nation as a whole. So we really want to make sure that we work in that area. This voter participation measure is an example of some of the things that we think need to be measured because a vibrant democracy is a healthy democracy. A value on health and well-being. Look on our new website, cultureofhealth.org. You will see the results of the first national survey that we did with the University of Chicago around how Americans are thinking about well-being. And we will be reporting on that, and you kind of see where things are going across over the course of the years on that one. On fostering cross-sector collaboration to improve well-being, I'm just going to mention one measure Risa didn't mention, which is community policing. We developed this measure actually before the sequence of tragic events, but now make this seem like, of course, this is a major component of well-being and a key to ending some of the mistrust and practices that have too often plagued our country over the last year and a half. So we're working to measure the prevalence of community policing in neighborhoods and create a dialogue to improve that. And we're also recognize that business and workplace well-being is key and important in this, and lift up the importance of community partnerships. I'll just mention a couple of other measures that Risa didn't call out as much. Residential segregation in there as an evidence-based measure for one of the major causal pathways for health disparities based on race and ethnicity. And I point you to our report because you can dive deeper into this and really see that it's kind of hard to get a sense of all of this together if we don't all live together in some better way than we do now. So take a look at that measure. They can go more deeply in it. As Risa mentioned, if there's kind of one thing we could all do, if we could put all our chips on one thing, it would be to radically transform our focus on early childhood and our measure around states that are having a higher percentage of kids in good licensed early childhood is really important there. Integration of health systems, again, only 41 measures, but I thought this practice law for advanced nurse practitioners to keep advancing as you're trying to do is a key sentinel indicator, relates to the challenges you guys have developed, but dental hygienists have been doing that work. We need all of our health professionals to work at the maximum level of their training. That's the only way we're going to deal with the access issues, and we want that one to lift up that. And then hospital partnerships. I know a number of you are working in hospitals. We've been working with the AHA. We think the hospital community interface, the interface between population medicine and population health, really is something that we've got to do in the future. Equity and well-being. Long-term, as Risa said, how can we really improve our health and healthcare over the course of the next 20 years? We've got some really good research on a community level. I'm just going to mention, since I've already gotten the stop sign, that will give us stories from 30 communities about how they're doing collective impact. We as your report with IOM pointed out, our measures resonate very closely with the IOM vital signs measures. John will talk about the resonation between the measures that we think matter for improving health and CDC. A lot of other social movements that all of us are aligned with that I think are trying to also promote well-being. You know about our changes in advancing change leadership that are leading to that, and Armenia Plough, who is leading that effort for us, will be talking to you later in a dialogue about that. We need the kind of leaders who know how to do this. And just go to RWJF.org, funding alert, for I know there are many nursing researchers in here, many research opportunities for you to help us understand and build this basic science for a culture of health. Cultureofhealth.org is where you can get it. We're really excited to be with you here today, and I hope all of you can see yourselves in your work and your action strategies in our work. Thank you.
So I want to talk to you about what we think is a critical issue at CDC right now that very much aligns with the topics we've been talking about. And in terms of thinking about that, I'd show this slide to you. It shows CDC's three strategic directions, and the one I'm going to focus on is the one at the bottom, and that's strengthening the linkage between public health and healthcare. And I'd ask for each of you to think about the ways that we can take advantage of this critical moment we're at now to build those linkages in nursing between public health nursing and clinical nursing, where there's real opportunity for partnership and advance. I'd say that there are a few reasons why this is so extraordinary a time period. One that really prompts your involvement in a leadership role in the communities and states you're in. I'm just going to mention three of those extraordinary circumstances. One, dramatic increase in access, an increase now in 17 million more people have health insurance than they did just a few years ago. 17 million. But that also is a challenge. That creates challenges in terms of public health nursing and clinical nursing that are quite significant. Secondly, we are seeing a dramatic change in terms of the way healthcare is paid for as we move away from fee-for-service to being the routine, to doing more value-based contracting. Value-based contracting offers the opportunity to do creative and different kinds of activities where the outcome may be good, and that means that some activities that have gone on for years or some activities we've needed that haven't been paid for now could be paid for under value-based contracting. I'll give you some examples of those in a second. And the third area of change is we're moving now to the sort of official federal government position that the best way to receive your health care is through a patient-centered medical home. The idea of having a comprehensive primary care site where even behavioral health is carved in a single location. Community health centers are key in terms of that, and obviously nursing is key in terms of managing that comprehensive care. But there are challenges associated with all of those changes. This gives you just some of those challenges. When you've got 17 million more people who are coming in, say, for the first time to see a primary care doctor, to get a physical, that's a lot of new volume. It's also a lot of opportunity to offer preventive care in the context of primary care. We've got to prioritize that in terms of moving upstream if it's going to actually happen. Secondly, I think that we're going to see more and more complex patients because we're going to see patients who haven't been insured that are coming in to care with a backlog of health issues and a lot of socioeconomic issues. Those issues are going to be needed to be addressed not just in clinical settings, but in partnership with community agencies and public health nurses. And sadly, though, we're also seeing a decline in terms of public health nursing at the local and state level, as we've lost something like 50,000 jobs in public health since 2008, and a lot of those jobs have been public health nursing. So we have to be very thoughtful about how to target those resources in the most effective way, particularly in a period of time where we're changing and some things that were provided by public health nursing may be shifted over to primary care settings, and freeing up some of the public health nurses to do different types of activities, maybe moving more upstream. I'm going to just quickly mention that those of us at CDC have been working on winnable battles for some time, and that offers you some sense of activities that are worthwhile doing, but I'm not going to go into those now. What I am going to do is highlight for you a framework that we think is useful for working at your state and local level on these changes that are taking place. In almost every one of your states, there is some core group of people that are thinking about the transformation of health now and designing new systems, new payment systems, new ways of providing care. Some of that is being driven by the fact that CMS has given out $1 billion in grants to state innovation model grants, and that those grants require a team of the commercial and the Medicaid program, sometimes Medicare too, designing a new system together with large providers. All too often, when those groups are meeting and redesigning these systems in very significant ways, there isn't a nursing leadership presence at the table, and that is a missed opportunity. And so I'd really encourage you, if you're not already aware of it, find out where in your state those meetings are taking place. Sometimes it's the state innovation model, sometimes it's somewhere else. Find out where it's taking place and fight to get to the table. Get to the table, and then get to the table with a set of some specific concrete proposals that can be useful in the context of those very important changes. What this suggests, this three-bucket approach, is that we need to think about population health when we get to those tables. And population health is a confusing term because it can mean different things to different people. We think this framework, the three buckets, is a way of illustrating we need to work in all ways that people think of population health and prevention. Bucket one is looking at what's already covered by insurance. That's the screening, immunizations, counseling patients on high-risk behaviors. But even though it's covered, our utilization is way below what it needs to be. And these redesign efforts now are thinking of ways of incentivizing with reimbursement and other approaches, making sure we're doing a better job on the traditional preventive measures that are covered. And remember, 17 million more people coming in. We want to make sure we catch them up as well. Bucket two is the opportunity with value-based contracting, where you can think of those things that very often nurses have spearheaded the way on how to do effective care, but there hasn't been reimbursement for it. One example of that is the Nurse-Family Partnership, where that's an intervention that works. It's been largely funded by grants. We have the opportunity with value-based contracting to say, bring it up to scale, pay for it with value-based contracting so that we can provide those kind of services to all the patients that need them. Bucket 3 moves away from the first 2 buckets, which are focused on clinical care, and thinks about what can we do to change the conditions in the community. This very much is aligned with the Robert Wood Johnson culture of health metrics that Alonzo was just talking about. Those are very good indicators of where we need to focus some attention if we want to create healthy conditions in the community. If we can, it's good to have alignment of those 3 buckets in terms of initiatives. So we're working in a clinical setting, in traditional ways, but pushing the boundaries with value-based contracting, paying for more community services for patients, and also simultaneously changing those conditions in which people live, work, and play. I'm going to give just a quick example of where you can get some tools to help you if you want to learn more about some of the work that we're doing to support those discussions. We've worked at CDC to identify some of the areas where the strongest evidence exists, that there are clinical practices that if we did those, we would be able to save money and we would be able to improve health in 5 years or less. Largely, these are population and prevention focused. They're in the 6 areas you see there. The 6 areas were selected because they're high burden areas where there's a strong evidence base about what could be done better to improve health. This initiative we refer to as the 618 initiative. Go to cdc.gov/ type out the word 618 and you'll read more about it. But it's also in your packets. There's a 1-pager on the 618 initiative. Here's an example of hypertension with the 3-bucket approach. With hypertension in 618, we're pointing out that one of the major, something we know works with hypertension control is to think about a team-based approach and a clinical setting and community-based approach in terms of helping people to control their hypertension with home-based screening, with home visits, with linkage by telephone and computer, and with having a full array of different clinical disciplines involved. So that's on the clinical front, things that could be changed with the existing reimbursement. A more innovative approach involves actually moving outside of the clinical setting, doing those home visits that I was mentioning, or doing more telephone counseling of patients. And then at a population level, that 3rd level that I was mentioning, you could work on having an influence in terms of creating healthier environments where weight control is possible, where healthier food is accessible, where physical activity is easier as the easier behavior. Again, very much aligned with the Robert Wood Johnson Foundation's leadership in that arena. CDC has a wide array of resources that are available. The main website to get on in terms of looking at those different resources, which may help you if you are interested in finding out where are those locations in your state where those discussions are taking place, how you can become involved in it. Please come to our website. We'll help to both let you know about that, but also to provide you with some materials that may be helpful when you get to those meetings. And that's available at cdc.gov/policy. That'll get you to a page of resources, and you can navigate around it to get the specific information you'd like. Thanks very much.
Thank you, John. What I want to do is give you equal doses of instruction and inspiration about how you take this home and do something with it in your own setting. The picture before you on the screens is the model of health that we use to describe health as we measure it in the county health rankings. And when I say this resonates with my nursing roots, when I look at that model of health, it's a social determinant of health or a multiple determinant of health model. And nurses, we've been doing this since Florence Nightingale and Lillian Wald. They all taught us about holistic care, about the environment being important, about the social environment being important, about connection to other people being important, about making environments where making the healthy choice, the easy choice, was the way that we could support patients and clients and neighbors in their health journey. So I hope you look at this model and say, that's a nursing model. And therefore, who else should be at the front line of moving this culture of health forward? So John just talked about this, and Alonzo talked about populations, and so I'm not going to dwell on it. But going back to Susan Denser's question about how does this matter to a critical care nurse, we all deal with populations wherever we are. What I don't want you to take away today is say, oh, the Future of Nursing campaign has gone completely public health and it has nothing to do with me. Okay, because I think there's that risk there for people who work in acute care. So if you work in acute care, your population are the patients that are on your unit. It's new moms having babies, it's critically ill people, it's children in a pediatric unit. If you work in primary care, it's the patients who present to your clinic. We all, however, live within community. So it is also, it's not either or, it's both and, those people before you and people in community. So what the County Health Rankings does, and I invite you to go to countyhealthrankings.org if you would like to on your device. I do not mind talking to people who are looking down. Is what we have done is given you an annual checkup of your community's health. We measure the health of nearly every county in the United States annually, and we provide you with an annual snapshot of the health. And we do it in a contextual way that tells you how your county ranks in comparison to other counties within your state. So if you're on the website and you click on your state, you'll come to a map. Since we're close to Maryland, I picked Maryland. And the map shows, in terms of health outcomes on the left-hand side in the green shaded map, the places that are doing better in terms of length of life and quality of life. The lighter the color of the county, the healthier, the darker, the unhealthier. Similarly, when we look at the health factors that contribute to how long and how well we live from that model of health I showed you, we look at measures of health behaviors, clinical care, social and economic environment, and the physical environment. You'll see it in the blue-colored map on the right. So then you say, that's lovely, but I want to know about my own community. And so then you simply click on your county, and you'll get to what is called your county snapshot, which will give you all of the specific data we use to calculate the rankings. It'll show you the relative rank of your community, both in health outcomes and health factors, and in each of the subcategories. So the point of this is, because we want to raise awareness that many factors beyond medical care influence health, and we want people to pay attention, and we actually want people to get upset. And we consider it a success every year if we get a few angry calls from mayors or county commissioners or hospital administrators or public health directors yelling at us about how dare we put this data out in the world. Because the majority of times we get those angry calls, we have this great opening to say, what does that mean and what can we do about it? So that's what the rankings is about. It's about taking action. It's about, as the Culture of Health Framework says, it's about how we all are in this together and need to come together. And what I would encourage you to think about is, as a nurse, how do I think about those multiple determinants of health in my own practice setting? And then how can I contribute on a board, in a leadership role, participating in your hospital's community health needs assessment? Every one of those should have nurse leadership. Your local health department's needs assessment, every one of those should have nurse leadership to move health forward. So, in addition to data, we also provide you with an action center that is chock full of tools and guidance around how to move health forward at the community level. It includes a database called What Works for Health, where we've already done the literature review for you on different policies and programs to affect those different health factors, and so you don't have to start with a blank screen. You can start with seeing where the best evidence is about strategies to move health forward. So those are the instructional pieces, the tools. But as we mentioned before, we also are looking for what we can learn from communities that are already doing this. And so we have also led the work in collaboration with our colleagues at RWJF to identify communities that are beacons of progress and beacons of hope for moving health forward. And so on our website, on the Foundation's website at rwjf.org/prize, you'll find the stories of 20 communities that are moving this forward, including New Orleans, that you'll hear from Charlotte, my great friend Charlotte, in just a moment. But these are kids from Everett, Massachusetts, a 2015 prize winner. And I just want you to take a moment and look in the face of those little boys with their hula hoops in a street party supporting a culture of health and say, how can we not have hope moving forward about how we're going to create this nation where health is that basic human right. So as we think about that, and as you think about your own community, I want you to think about these 6 criteria which underpin how we select communities for the Culture of Health Prize. One is, how is your community defining health in the broadest terms? And going back to that model of health, it's also on a handout in your packet. How are you thinking about health where, in particular, the social and economic factors are not just demographics you describe patients by or populations by, but they are places we take action to improve health. So it's when you sit on the school board and change the lunch menu, and change the curriculum, and change the policies to make sure that children who are being truant in early years, that there are interventions to be sure they stay in school, because that's what we know leads to graduation. How are we thinking about those interventions as health interventions? It's about looking at policy, systems, and environmental change and having a long-term view. It's about New Orleans passing a smoke-free law. It's about how do we create a system where early childhood education is as easily accessible to every child in your community as K-12 education is. It's about all of those kinds of policies that you move forward. It's about how do you put the nurse family home visitation program in your community and make sure it isn't subject to the whims of grant programs, but you make sure it's funded in a sustainable way. It's what we've talked about today. It's about equity and making sure that we are looking out for the health of every single person in our community, and we're including the voice of those most affected by poor health in all of the decision-making and solution identification. I remember working with a public health nurse who spent a good part of her early part of her life living in a trailer home. And I learned more about poverty from her than I did in any academic book I ever read. So it's about really having people with lived experience side by side with us. It's about working across sectors, and we've talked a lot about that. It's about using resources wisely, and it's about using the resources and assets that's already in your community, not just waiting for the next best great grant from CDC, but finding it within yourselves. And finally, it's about measuring and sharing progress and results. Yeah, he's pretty determined too. So as I wrap up, there are many, many opportunities in nursing practice. And I've spoken about several of these as we've talked about, but we know how to think about the multiple determinants of health in all that we do. But it's about thinking, how do you change the environment where you work? We can all start in our own home, in our own workplace. It's as simple as getting rid of the soda from the soda machine. I know that's not simple. I was the head of a health department, and taking the Coke and the chocolate bars out of the kitchen were some of the greatest challenges I faced. But It's looking at all of those environments and looking where you are. It's serving on those community boards, so thank you to the campaign for doing that. I served on the school board in Marathon County, and 10, 15 years ago, we changed our curriculum around guns and stopped doing gun education and handling of guns in a 6th grade school forest experience. It's that kind of leadership in your community. And in nursing education, I hope every faculty member here uses the county health rankings in some way in your courses. It is a readily available tool, and I've heard from many of you that you have found it to be very, very helpful. And we need students learning about board governance, shadowing us on boards, serving on boards like our great student nurse leaders here today, and modeling that for us. So that whole area of service learning and thinking about being a nurse from the bedside to the organization to the community is how we will seed our future leaders.
I am going to tell you a story. I don't have any slides, but we do have a wonderful story to tell about New Orleans and the rebirth of this city in terms of the city itself and in terms of health in general. Our odyssey started, as everyone knows, with Katrina, a disaster that brought blessings to this city in terms of being able to reset and restart and figure out what makes sense for our city and what did we want to become going forward. In 2010, before that, for Katrina, I was working in direct healthcare in a hospital and was in the hospital during the time of Katrina and stood there for about a week after Katrina. And the bottom line for me was I got to see in action not only what healthcare could do to help save what we needed to save during that time, but I also got to see firsthand the inequities of what went on for the people who did not have the means to be able to get out of a city, the means to be able to go anywhere, evacuate, those sort of things, and how did that affect that? I was a maternal child director at the time with a unit full of mamas, babies, NICU babies, the whole thing, and had to figure out how to get them out. So from that job of getting everyone out and moving on, it gave me an opportunity to really think about where was my career going to go going forward, and decided that I wanted to be in public health. And I wanted to figure out how to start at the beginning versus at that acute time that people needed things. Went to the city's Department of Health, worked for a program called Healthy Start New Orleans, and ran that program. And so I got to keep my love of mamas and babies, but also got to move into public health. And we had an election, got a new mayor, and he has a focus on health and wanting to make sure that the health of his citizens are basically attended to, and what can we do to move forward. Worked with a wonderful person called Dr. Karen DeSalvo, who was the health commissioner for the city, and I was her deputy at the time. And we made a commitment to transform the health department to something that was focused on those issues that were inequities for our citizens. And we used the public health accreditation process as our roadmap to do that. RWJF was one of the first groups to recognize the work that we were doing in terms of transforming the health department through a program we had called FitNOLA at the time. And FitNOLA's main focus was to, we were a Let's Move city, and it was to look at childhood obesity and bring the sectors together that wanted to work on that issue. And so we had sectors in economic development, early childhood, parks and recreations, all the things that you would think are interested in doing this. We invited people to this meeting. We thought we'd have about 25 people. We had 200 that showed up and said they wanted to be part of this movement. And FitNOLA is still alive today. is going to receive some funding very soon that we are going to be announcing to keep that going and sustain that program. And it still has over 200 partners today working on those different sectors. So that was our first movement into the culture of health and how do you change that. At that time, Dr. DeSalvo and I thought about what we wanted to do, and smoking was one of the things that we wanted to bring to the table at the time. But in leadership, you learn to figure out when the timing is right to do things. The timing wasn't right for New Orleans at that point in time. We were going to get a lot of pushback on doing that, but we laid out our plan, thought what we wanted to do, and from the health department leading that, what would that look like? A couple of years down the line, it came up again. And the leadership at the time changed. Dr. DeSalvo has since moved on to work in the Obama administration, and I took over as the director. And one of our council people became extremely interested in the smoke-free piece of this, but from the view of workers and workers being able to work in a smoke-free environment and how is that going to affect them. And there was, of course, as you all know, lots of data out there about smoking and the effects of smoking, what was that going to be. But data wasn't the only thing that was going to drive this for us. Data was important to back it up, but this is where nurses come in and you change the dialogue on the story because the passion is what really drove this. It started with the passion of people going to the council meetings and talking about family members and co-workers who had cancer or died from cancer, all of those things that you wanted, and then, boom, hit them with the data, right? So they got the story first, those passionate stories, and then you were able to lay it on with the data and say, this is why, and so people listened, right? The businesses came, they complained, we had people who got up to the podium who were longtime smokers, and you could hear it in their voice, but they were still there telling you they wanted to do it. And the bottom line was, when it came down to the vote, all of the council voted that we were going to do this. And in the face of all of that, that's where the health department then came in, because our job is to enforce that and to go out. We looked to other cities, and we said to those other cities, tell us how you did this. New Orleans can't be that different, right, in terms of laying this out, but we look for best practices. This is what we should all be doing, looking for those best practices. Don't reinvent the wheel. You don't have to. It's out there. Brought the best practice in of educating first, using public health education and going out to everyone and saying, this is what we're going to do. This is how we're going to do it. We're not looking to take your liquor licenses. We want you to make this a healthy place. By the time we rolled out the ordinance and it went into effect, which was about 6 to 8 weeks after we did the public health education, it rolled out without any problems. It has now been in effect for close to 8 months, and I can tell you we've had less than 20 complaints of people who are not compliant. We have only had to go back to 2 businesses and reinforce what needed to happen. When I walk through the French Quarter now, and I see our signs hanging up all over the French Quarter because we created our signs and could go down the I'm walking with my husband, there's our sign, there's our sign, there's our sign. I walked into a high school who they are not required to do that. There's our signs. People in New Orleans wanted to change their culture, and they wanted to begin to have that healthy culture. And one of the first things was with smoking. Now, we got big problems in New Orleans. We have a violent culture there that we are trying to figure out now how to break. The health department's role, and this is where nursing can help, in hospitals actually, this is where you can help if you are a direct care nurse. You have someone who is in your ICU who's been shot. You have an opportunity to talk to their families about what that looks like, connecting them with community health programs that may be able to drive this somewhat differently. There are opportunities out there, and as I put on another hat recently, I've been functioning as interim CEO at a new hospital we built in the city. And I've gotten to go back to my roots now and see nursing again from that direct care perspective. And my role now as a public health nurse I can look at the direct care, and I'm starting to see ways that I can combine what's going on and how can I bring that back to the hospital, whether it's population health, whether or not it's bedside nursing, and reconnecting nurses back to what those determinants are. When I got to the health department, I found a book. And you know how you go in, I don't know if y'all know, but health departments are places, we're hoarders, keep lots of stuff, lots of stuff. And we had boxes and boxes and boxes of all kinds of things that were there. And the first thing I did, because I'm a mama, right, it was, we gotta clean this place up. I can't work in this upset. I found a book of photographs that were taken of the New Orleans Health Department over many, many years, some 50, 60 years old. I got to see a photograph of the first, what I call GIS system, right, in a health department. And literally, it was a big wall map, and it was a map of all the babies born in the city of New Orleans in 1940, right? And it were just dots, manual dots all over this map. And it was just so, you know, when I looked at it, everything that's old comes back. And so GIS mapping that we do now, and we do it in a computer, and you get to put it all up here. We were doing analytics so long ago. Nursing was doing it so long ago. We have not taken the lessons we knew, and we've not quantified it, and we need to quantify it. You know, and nursing has the power to do that, and that's what I'm learning in my journey as a nurse and moving into other things and all those interpersonal skills that you have to have. You know, I work with nurses, but I work with doctors, I work with social workers, I work with public health officials, I work with elected officials, trying to tell a story of where health needs to go and why nursing should always be at that table. So don't sell yourself short. Nursing should always put themselves at the table. Find it, assert yourself, make sure you are out there telling the story from nurses' perspective, because you already know what the inequities are. You already know what to do with the social determinants. You just need to tell the story and quantify it. And we're doing that in New Orleans. And there's so many things going forward that a lot of these communities are doing, but we are on the witness of the golden age, I think, of health in New Orleans right now. And, you know, to service the tourists that come in, who make our community stronger and put there, but also serving those citizens, right, who deserve to have the best of everything that we have to give them. Thank you.
Thank you, Charlotte. I believe that I am here representing my profession to help make the connection between what we're talking about, the culture of health, and city planning and what we can do working together. And I'm extremely excited to be here because there's a lot of stuff happening in my profession that you all should know about, and if you don't know about, I hope to give you just a little bit of an idea of what's going on so that you can get engaged, because we really need to bring you into this conversation that we're having in city planning. So for those of you who may not know a lot about city planning, we're the folks who work with citizens and local elected officials to plan your transportation systems, to lay out new communities, to revitalize existing communities. We write zoning ordinances, we advise policymakers on setbacks from streams and rivers, and the list goes on and on. City planning is all about community building. That's what we do. And we are now, after, I think, kind of divorcing ourselves from our original mission of protecting public health, that has become a more central core to the practice of community planning, and there's a lot of exciting stuff happening. So that has started, I would say, about 10 years ago as we became more aware of the obesity epidemic. And there were folks in city planning, in conversation with folks in health, that started asking, does the way we design our communities, our transportation systems, the placement of housing, the distance of housing from offices, et cetera, does that impact health? And so some really core research was done. And I'm just gonna read off a few titles, and those titles speak for themselves as to what I'm talking about here. So the first, 2003, relationship between urban sprawl and physical activity, obesity, and morbidity. Neighborhood-based differences in physical activity. And two that I have up here, because I think they are the best of the evidence-based research into something that's very accessible to the average reader and interested in this topic. So urban sprawl and public health, making healthy places, designing for and building for health, well-being, and sustainability. Now, this research has really stimulated a number of organizations to collaborate in trying to put some of these concepts of building healthy communities into practice. So as an example, the American Planning Association in 2012 released Healthy Planning, an evaluation of comprehensive and sustainability plans addressing public health. And this past April at their national conference, they had an entire track of health and planning. And this is a conference that attracts over 7,000 planners from across the country. And I attended one of those sessions, and there were city planners there from Phoenix who, by the way, city planners also do geographic information systems analysis, and we're really good at mapping. They had done a mapping exercise that showed that women from lower income communities who qualified for SNAP could actually not reach SNAP centers because there was no public transportation and there was no sidewalk network, and the distance was too great to actually have children in tow and be able to get to those centers. Just last month, I had an opportunity to speak with Cynthia Stone, who's a nurse on the faculty of the School of Public Health at Indiana University, and she's working with student planners and that faculty from this planning school to do health impact assessment. And this is something that more and more planners are being trained how to incorporate into our comprehensive planning efforts. And it's really changing the dial on community conversations and what decisions are getting made. So things like with our limited dollars, how are we investing those dollars in community? Are we investing them in building more roads, in public transportation, in building sidewalks and bicycle networks, in parks, in farmers markets in low-income neighborhoods? All of these decisions get made in that realm of community planning and the local policy making. So my key message for folks here today is that we need your help. And there is quite a lot of movement around this. The Surgeon General just put out this call to action on walking in walkable communities. And within this call to action, there are several areas that touch upon city planning. For instance, designing safe and easy places to walk, parks and recreation facilities, implementing safe routes to school with school districts. City planners, we know how to design walkable and healthy communities, but we face obstacles pretty much every step of the way. And just one example of that, it might be the property owner who blocks having a sidewalk built in front of his home that would connect the city, the neighborhood, to an entire network because he's concerned about liability and if he doesn't shovel his snow. So we need nurses, the health community, to come into these conversations to help communicate the importance of providing these healthy, walkable type of communities. We also need to hear your stories, and unelected officials hear your stories of how your patients may have forgone important preventive care because they lack transportation to get there. We need those individuals making those decisions to hear that there are people in our communities that are actually choosing between putting a roof over their heads, and paying for medicine. And these are just a few of the possible connections between my field in city planning and yours in health. So, with that introduction, I want to share with you a new tool that the AARP Public Policy Institute has developed. And this is an online tool that is available to all of you, similar to the county health rankings. We call this our livability index, great neighborhoods for all ages. We could have also called it a health index. There's a lot of similarities in measures that we have in our livability index and what's in the county health rankings. And in a couple of cases, we're actually pulling data from Charlotte's tool for our index. But what this does, as you can see here, it allows you to type in a location. This can be an address, a city name, zip code, state, We measure every neighborhood and community across the entire United States, whether you're urban or rural, red or blue. Every place in America gets a score in our livability index. So just a little bit how it works. Once you type in a score, you get a results page, and you can see the total score for your community on a scale of 0 to 100, with 50 being the average community. Each of those total scores are built up from the category scores, and we have 7 categories of livability: housing, neighborhood, transportation, environment, health, engagement, and opportunity. I should mention this is an index for all ages. While we chose some indicators through the lens that AARP brings to the table, it's as applicable to young individuals in the community as it is to older adults in the community. And we really designed the tool to help folks stimulate those conversations at the local level, to talk about if your issue is transportation, then tie it to the other health issues that may be those conversations in the community. So for instance, under health, we include healthy behaviors, the smoking rates, obesity rates, access to exercise opportunities, preventable hospitalization rates, and patient satisfaction. And this is a combination of metrics. These are our quantifiable metrics where we're pulling data from more than 50 different data sets into the index across these 7 categories of livability. And then we also have our policies, 20 policies across the 7 categories. And once we've calculated a score for the category, say health, then we give communities an additional policy point for every policy or program they have in place that we're measuring. Smoke-free air laws, comprehensive smoke-free air laws is one of the things we're measuring under health. So the next go around, New Orleans will get an additional policy point on our livability index. So bravo, congratulations. The neighborhood category of livability is really the city planner's quintessential definition of what constitutes a live, work, play type of community. And these are measures that look at how close is your neighborhood? Is it within walking distance of these various services, such as grocery stores, farmers markets, parks, libraries? Can you get to jobs by a reasonable commute on transit or driving? It's kind of that activity density, jobs, and people within the neighborhood. Also looking at crime rates and vacancy rates under neighborhood. And these types of measures together really paint a good picture as to how walkable a community can be. So if you do well on our neighborhood score, chances are there's a lot of people out walking in your community. And we actually measure that under transportation. We do measure walk trips. We worked with the University of Utah to do peer-reviewed modeling down to the neighborhood level of walk trips for every household in the United States, or at that neighborhood level. So that's new data that's available to you. And on transportation, we're looking at what's the frequency of buses and trains and the accessibility of that fleet within the neighborhood. So just one more thing that I want to show you from the index. You can pull down different map layers. And one of the most powerful map layers that I think is in here is life expectancy. And these are maps from the Northwest United States compared to the Southern United States, Arkansas, Louisiana. And you can see the green are longer life expectancies. There's actually a 3.5-year difference from one area of the country to another, and this is at the county level, pulling data from Harvard. So that's the kind of power and tool in the Livability Index. You can find that at livabilityaarp.org/livabilityindex. Thank you.
Thank you, Jana.